Good afternoon, and welcome to the Mid-Atlantic Public Health Training Center's Public Health Practice Ground Rounds for April 2009. My name is Molly Mitchell, and I'm the coordinator of the Mid-Atlantic Public Health Training Center. And on behalf of the Training Center and the Maryland Department of Health and Mental Hygiene and the Maryland Public Health Association, I'd like to welcome you today for our presentation on Healthy Babies Are Dying, Understanding and Preventing Sleep Environment-Related Deaths in Infancy. And before we begin our presentation today, I'd like to invite everyone on our website to make sure that you check out our upcoming programs and trainings, including a continuation of our public health core competency training with our own Carolyn Fowler, who is one of our presenters today. Topics coming up include developing professional partnerships in public health, working with data, public health nursing. And so we invite you to go on our website and learn more about the details of those trainings. Also, for those of you watching online, we invite you to email questions at any time during the presentation to our email address at maphtc@jhsph.edu. And we also ask, if you're watching with a group of colleagues, to please send us an email and let us know so that we can have our numbers accurate to let our federal funders know. And with that, I'd like to go ahead and introduce our speakers for today. First, we will have Dr. Stephanie Regenold. Dr. Stephanie Regenold is a senior advisor to the Babies Born Healthy Initiative at the Baltimore City Health Department. Dr. Regenold received her medical degree from McGill University. She completed her family medicine residency through the University of Maryland and Franklin Square Hospital. She received her master's in public health from the Johns Hopkins Bloomberg School of Public Health and completed her residency in public health and preventive medicine through the Maryland Department of Health and Mental Hygiene and St. Mary's Hospital Medical School in London. She has worked as a healthcare provider in Baltimore City's sexually transmitted diseases clinics at the Homewood campus of Johns Hopkins University and as a family physician in Portland, Oregon. In 2004, she became the coordinator for Baltimore City Health Department's Infant Sleep Safety Initiative and continues to work on issues related to infant sleep safety. She is also a consultant for First Candle, a national nonprofit that promotes safe pregnancies and the survival of babies through the first years of life. Dr. Regenold is a member of Baltimore City's Fetal and Infant Mortality Review and Child Fatality Review teams. We also have with us today Dr. Carolyn Fowler. Carolyn is an assistant professor at Johns Hopkins Bloomberg School of Public Health with a joint appointment in the School of Nursing and core faculty for the Mid-Atlantic Public Health Training Center. She has more than 25 years of clinical research, teaching, and practice experience. I didn't want to add too many years on there, in public health. After training in nursing, midwifery, and community medicine, she completed her PhD at the University of Cape Town, South Africa, followed by a postdoctoral fellowship in injury prevention and an MPH at Johns Hopkins School of Public Health. Since that time, Dr. Fowler has been a core faculty member of the Center for Injury Research and Policy, where she is academic director of the Johns Hopkins Summer Institute Principles and Practice of Injury Prevention. Carolyn's primary professional interest is the development of core public health capacity in practice settings. Since 1999, through a contractual relationship between Baltimore County and Johns Hopkins Bloomberg School of Public Health, she has directed injury prevention activities for the Baltimore County Health Department. And last but not least, we have Dr. Scott Krugman. Dr. Krugman is chairman of the Department of Pediatrics at Franklin Square Hospital Center. Dr. Krugman graduated from Dartmouth Medical School and completed his residency at Johns Hopkins Children's Center. After residency, he became a member of the pediatric faculty at Franklin Square Hospital Center and assistant clinical professor of pediatrics at the University of Maryland School of Medicine. In 2002, he became chairman of pediatrics at Franklin Square. Dr. Krugman completed a master's degree in epidemiology in 2005 and in 2006 was appointed as clinical assistant professor of epidemiology and preventive medicine at the University of Maryland School of Medicine. He founded Franklin Square's Child Protection Team in 2000 with the aid of a VOCA grant, which evaluates over 250 children at the hospital each year. In 2002, a Maryland Children's Trust Fund grant helped start the Prevention is the Best Medicine program to work on child abuse prevention efforts in eastern Baltimore County. Dr. Krugman is also co-chair of the Baltimore County Child Fatality Review Team, the Baltimore County Child Protection Review Board, the State Council on Child Abuse and Neglect, the board of the Family Tree, and is secretary-treasurer of the Maryland chapter of the American Academy of Pediatrics. And with that, I'm going to turn it over to our first speaker. Thank you.
Thank you. Good afternoon. We're going to be talking about understanding and preventing sleep environment-related deaths in infancy, and just start with a little discussion about the role of unsafe sleep in infant mortality. Why look at infant mortality? First, to define it, infant mortality rate is the number of deaths among infants per 1,000 live births in a given year. An infant is defined as a person from birth until the first birthday. The infant mortality rate is easy to compute. You just need population data and mortality data. So it's relatively inexpensive, and it's easy to compare populations. Okay, now why look at infant mortality? It's long been seen as a general indicator of the overall health of a community. It's the indicator of health of the present population, the pregnant women and fathers, and the future populations of the infants. It's an indicator of health disparities among different populations and an indicator of the overall health and quality of life in a community. This, it might be a little difficult to read, but this actually was published in the New York Times just a few months ago, and actually was published again last week in the Science Times. So that's how important an issue it is nationally. This points to two different years. In 1960, the United States was ranked 12th among all nations for infant mortality, and that ranking dropped to 29th in 2004, which is the latest year for which these comparisons are available. This is despite the fact that America spends more than twice the amount per capita on health care than any other industrial nation. The infant mortality rate in the U.S. overall in 2004 was 6.78. It actually did not change significantly in 2004. It did not change significantly in 2005, and hadn't changed from the 6.84 in 2003. And actually, the plateau from 2000 to 2005 is the longest period of the infant mortality rate not declining in the U.S. since the 1950s. The range is from 4.67 among Asian and Pacific Islanders to 13.6 among non-Hispanic blacks. I'll say in Baltimore City, the infant mortality rate is around 11, and among African Americans, it's 15. The Healthy People 2010 infant mortality rate goal is 4.5, so we're over 50% higher than that nationally, and much higher locally. The leading causes of infant mortality in the U.S. are congenital malformations, low birth weight, and SIDS, and putting SIDS, sudden infant death, sleep-related deaths, all under that umbrella. Together, they account for 45% of all infant deaths. Post-neonatal infant mortality is defined as the death of an infant from 28 days to 1 year of age. And SIDS and sleep-related deaths are the leading cause of post-neonatal mortality in the U.S., in Maryland, and in Baltimore. What is SIDS? SIDS is the sudden infant death syndrome, the sudden death of an infant younger than 1 year of age that remains unexplained after a thorough case investigation. And Drs. Fowler and Dr. Krugman are going to go into this in a little more detail. So I'm going to go on to just defining, when I talk about SIDS, I'm talking about SIDS and sleep-related deaths, all sort of sudden infant death. And there's not really one known cause of this, and there are many theories, and the leading theory of what causes a sudden infant death is called the triple risk model. It requires the convergence of 3 elements that may lead to the death of an infant from I'm going to call it sudden infant death. Critical development period, a vulnerable infant, and then outside stressors. And the idea is that all 3 of these have to be present for a death to occur, and that removing one or more of the outside stressors can greatly reduce the risk of SIDS. And just to put it a little more schematically, there are these 3 elements. And I think this is just, we're going to be talking about this later, but I think just to keep in mind as a framework for thinking about SIDS and sleep-related deaths, that these 3 overlapping elements. One is the critical development period here, and that's just a period in an infant's life where there's vast physiologic changes in homeostatic controls, change in regulation of respiration, heart rate, blood pressure, which actually is greatest in the first 6 months of life, which is when most SIDS deaths occur, but continue on for the first year of life. Then the second element here is the vulnerable infant. And it's under this theory, it's believed that certain infants have some defect in the regulation of heart rate, blood pressure, cardiac function that make them prone to succumb to death during this critical development period with these outside stressors. And a lot of the studies that have looked at these infants have been autopsy studies. So they've been studies on infants that have died of SIDS compared to studies of infants who have died from other causes. So it seems that there are some vulnerabilities in certain infants. We don't know which infants these are. And then the outside stressors, which include the stomach sleep position, soft bedding, tobacco smoke, overheating, and upper respiratory infection. And again, we're going to go into these in more detail, but just to keep in mind, an example, a baby who's sleeping on his stomach, who's rebreathing expired air, which has decrease in oxygen, increase in carbon dioxide, a vulnerable baby will not get those mechanisms in place to move, to arouse itself, increase heart rate, increase blood pressure, and that sort of things to get more oxygen, whereas a normal baby will. And that's stomach sleep position, soft bedding, all these things are sort of additive risks. Last week, the mayor of Baltimore, Sheila Dixon, released a birth outcomes strategy to improve birth outcomes in Baltimore, and it involved these 11 high-impact areas. And these are things that some or all health departments are involved in: primary health care in a medical home, obstetric care, home visiting, drug and alcohol treatment, intervention for domestic violence, mental health care, smoking cessation, family planning, nutrition support, breastfeeding promotion, and then safe sleep programs, which we're going to talk about some more. But I put this up there just to say that safe sleep education is a relatively inexpensive intervention and can be done in all of these settings. And as we know, with public health education, the more venues, the message is brought, the more that's listened to. Okay. Thank you.
Well, hello everybody. And I'm going to actually then move through and talk about how we investigate infant death and how we understand the problem as a precursor to preventing sleep-related death in infancy. So the first issue for us is that identifying a problem is important, but it's only useful for prevention if that identification leads to a sequence of careful strategic responses. And the issue for us is moving to a situation in which we truly understand what's going on with infant death so that we can have data-driven prevention. So this is the EPI Triangle, which anybody who's ever set foot in epidemiology classes has seen a million times. But essentially, we are looking, if we're looking at infant death, we have the triangle involving the vulnerable infant, the environment, and then the agent. And in this case, the agent is the deprivation of oxygen, some kind of hypoxic event. In injury, we talk about the agent being energy. In this case, it's the deprivation of energy below the threshold of tolerance. Now, one of the critical things to understand about infant death is that host agent and environment interactions differ very dramatically in children than in adults, and especially in infants. So we have this vulnerable for the first 6-month period, and the infants are interacting differently with the environment in 2 levels. Firstly, the environment is built, and secondly, the environment is used, because in some situations we almost see misuse of environments, such as cribs or beds, in infant death. Now, the prevention challenge that we have in infant death is finding information about all components of this epitriangle, and not just focusing on the infant or the agent, but realizing that there's an interaction variable going on here between the infant, the environment, and the agent. And what we also need to remember very clearly is that environment, in terms of prevention thinking, must involve both the physical environment and the social environmental variables, and we'll come back to that in a few minutes. So Dr. Regenold showed us this definition of SIDS, which says that the death remains unexplained after a thorough case investigation. And the critical question then for us is, well, what is a thorough case investigation? And that ties very clearly to who is investigating. And because we don't all live in Maryland, I think it's really important that we stop and think about why knowing who's doing the investigation matters so much in terms of child death prevention. So the answer to the question, who are your infant death investigators, really depends on where you are. The sad situation is that in the United States, we have more than 2,200 different death investigation jurisdictions. And that means that within any one jurisdiction, we have variation in training and protocols, which is going to influence the quality and consistency of the investigation, and therefore of the data available to us to plan prevention. I want to also talk about what's in a name, the issue of coroner and medical examiner, because this is really important for us to understand. A coroner, which is the person present in many, many jurisdictions in the United States, and is in fact the common term used by the media, is in fact not often or not always a physician. They can be anybody over the age of 18. They can be they're usually elected, so they're not independent of the sort of administrative or police system. Very variable training. Some require you to have a physician working with you, or some require maybe that you be a nurse or a physician, but that's not the case in many jurisdictions in this country. And typically they are found in smaller jurisdictions throughout the country. The medical examiners are appointed officials, and so they have a potential to be much more independent of the system than a coroner. They are forensic pathologists, which means they are qualified physicians, board certified in anatomic pathology and forensic pathology, and they are typically found in larger jurisdictions. They are also a fairly rare breed in that there are about 1,000 board-certified forensic pathologists in this country, and with 2,200 jurisdictions, you can do the math. They're fairly thin on the ground. If we look at the type of death investigation system throughout the country, we'll see that we have the coroner systems, these light coroner systems, very prevalent in the middle of the country. The medical examiner systems are predominant on the East Coast. Here we have a medical examiner system. They're not all statewide, so you may have medical examiner systems which have different medical examiners in different parts of the state, but there are also systems in which you have one medical examiner system for the state. And then there are mixed medical examiner coroner states. I'll explain what we're like in Maryland in a minute, but it's really important that you know who you have. The first issue to understand epidemiologically is you cannot compare data from jurisdiction to jurisdiction because they may have different levels of training, they have different levels of experience in the investigators. The investigators have different resources and, of course, different protocols. Now, CDC is currently leading efforts to try and improve this. Even though we're a long way from having ME systems all through the country, there is a really aggressive move to standardize the investigation and reporting of infant death. And for those of you who are interested, there is the Sudden Infant Death Syndrome / Sudden Unexpected Infant Death and SUDI initiative at CDC with recommended investigation protocols, and that website is there for you to look at. Now, in Maryland, we're really fortunate. We have one of the few statewide medical examiner systems in the country, which means that all sudden, unintended, or unexpected infant deaths in Maryland will be investigated by the Office of the Chief Medical Examiner. We have a statewide system, and that means that although, we may be wrong, we're consistently wrong, or consistently right, in that we have observer differences minimized because the same team of 16 or sometimes 17 pathologists is responsible for investigating the death, and their QA protocols require them to discuss those deaths. So I'm not saying we're always necessarily correct, but any sort of error is likely to be consistent within the state, and so we have pretty stable data. The importance of knowing that you have skilled forensic investigators and skilled forensic pathologists is really important, because the more skilled the investigator, the more likely they are to understand the importance of looking beyond the pathology. The pathology is critically important, but comprehensive forensic investigation goes way beyond just the understanding of the pathology. So the other thing that forensic investigators understand is the need to move between environments in terms of understanding what's going on. So in Maryland, what would happen is we say have the death happening in the home or some other site, such as a daycare facility. And obviously, we have emergency medical staff and police responding to that home, and our forensic investigator would respond usually to that home as well. If the child, which is usually the case, the baby, has been transported to the hospital, the emergency medical staff and police will once again have responded to the hospital. We have the hospital staff, and there's a great deal of variation there in terms of awareness. In Franklin Square, we have very trained and aware staff in terms of infant death. That might not always be the case in other facilities. But there's an investigation scene there as well, so the investigator will respond to that scene. And finally, then, the child will be transported to the medical examiner's office where the forensic investigation begins. So what is involved in comprehensive death investigation? Now, clearly, let's just start with the obvious. Anybody who's seen CSI would know this. That, of course, is a story for another day and a problem for many of us. But a forensic autopsy is not just the physical autopsy. It involves the external, internal, and histological examinations. It involves toxicological investigation, microbiology, and metabolic screens, and in some cases, particularly with infants, special tests, such as special neuropathological tests, etc., heart cuts, and so on. There's also the scene investigation, which is the police findings, the forensic investigator reports, any interviews with EMS, and so on. And then the medical examiner will consider medical history, the prenatal history, the birth history, pediatric and primary care history. And this is really important in terms of getting back to what Dr. Regenold said about vulnerable infants. We also include the social history. What is the family information? What do we know about the caregivers? Has there been any social services involvement with this family? Are there child protective services involvement? Because many of these may begin to indicate that we have a child that is socially vulnerable as well as medically vulnerable. Now, when we talk about SIDS, we have to understand that SIDS is a catch-all. And the sad thing, and this is something that many of us are trying to achieve in this country now, is to stop the regrouping of the SUDIs and the SUDICs back into SIDS. Let me try and explain to you the difference between SIDS and SUDI. So a SIDS is a death which remains unexplained after a comprehensive investigation. And that means that the autopsy, the histology, the tox, is negative, as is the review of the medical history, the scene investigation, and the social history. So in other words, nothing is coming up positive. The child may be in a crib without bedding, they may be face down, but there's no sleeping, there's no substance issues, and so on. A SUDI, as we call them in Maryland, a sudden explained death in infancy, or a sudden unexplained infant death, looks very like a SIDS up to one point. In other words, everything is negative in terms of the actual autopsy and investigation, but something is coming up positive or at least dubious. So either the child has, was maybe born drug addicted, or we have maybe a history of a previous infant death in this family. There is co-sleeping, there's the presence of, say, comforters and pillows and blankets. So there are other variables which say maybe there's something going on here which really is pointing to the external variables much more than anything else. And in that case, in Maryland, that's going to be called a SUDI with a manner of death being undetermined. And it's really important that we understand that when somebody says undetermined, they don't necessarily mean it's a homicide, and it doesn't mean they don't know what's going on. Basically, undetermined, as used by a forensic pathologist, means that there's no conclusive evidence to suggest whether it's natural, a homicide, or something else. So we're leaving that open so that potentially further investigation can be done. So it's not always ominous to say that it's undetermined, but it's not necessarily always a natural death. So when we say adequate review of risk factors, they include not only this comprehensive autopsy, but we also have to think about it slightly differently. We're looking at intrinsic risk, physical intrinsic risk, cognitive risk, developmental risk. So, for example, the fact that the baby can't lift his or her head, they're at risk for rebreathing, that kind of issue makes them more vulnerable. They may have acquired individual risk factors. This tends to be more of an issue slightly older. They may have physical issues, they may have behavioral issues. We have to think about physical environmental variables really critically, and we're going to spend quite a lot of time on that. We need to look at social environmental levels, not just the individual family level, but also the community and the systems level. So, for example, if a child is in childcare, what are the requirements for supervision and management of a child in childcare? What is the availability, for example, of safe, regulated childcare for a family? We look at injury or medical patterns and outcomes, and it's really important that the clinical picture that the pathologist and the clinicians are seeing matches the exposure. This is particularly true in the case of abusive injury, but it's also important for us in terms of what people say the child was doing at the time. For example, if they say the child was sleeping on their back, but we find, real evidence that the child was sleeping on their front in terms of post-mortem changes, we would begin to wonder why we had that change in story. There is also the methodology which aims to help integrate data, the data that is coming from the medical examiner system and the data that is known in other systems. And that really brings us to the issue of child death review teams and the multidisciplinary approach to understanding and preventing infant sleep-related death. The reason that child death review teams were established was the fact that there's no single health, social services, legal agency of any sort that exists to track and comprehensively assess all circumstances of death. So even if the medical examiner's office is doing a comprehensive investigation, which they do, a very comprehensive investigation, they're still really coming at it from the perspective of forensic pathologists. And so the issue is, can we create a structure which helps us stop looking at it from our own sort of job description and forces us to look at it collectively as a group? And the real reason for child death review was this total frustration that people experienced in trying to understand a complex problem from one perspective. So child death review is systematic, it's multidisciplinary, and the idea is the coordination and integration of data and resources from our forensic pathologists, law enforcement, and so on. So the real issue is people bring their information to the table, and there is a structured discussion of that information which leads to a process of decision-making and recommendation. And the idea is that with cooperation, we're able to see things and understand things, both causally and in terms of prevention and response, that we would not understand separately. So typically, child death review reviews pediatric deaths, usually up to about 18. We're not looking to blame people or blame victims. We're looking for system failures. We're looking for sort of system fixes. And we're also identifying and proposing response. Now, some teams just recommend response. There are other teams which actually move themselves to some level of direct intervention. Child death review tends to be unfunded, so we don't have a lot of prevention money. But in the case of Baltimore County and Baltimore City, both teams do some active intervention work, as you'll hear later. The problem with prevention is that choosing the intervention is not intuitive. We often see what we know, so if we always think that it's a parent's fault, we'll always look for solutions by telling parents what to do. So we really need to think much more critically about what our prevention and policy options are. The biggest situation I think that we find in child death review around the country is that people often are tempted to focus exclusively on one issue. So, we'll only focus on crib or crib distribution. We may look at public service announcement approaches. And the real challenge for us is to realize that we need to address the risk factors that are happening in our settings. So even though in some situations crib distribution may be a really good option, in Baltimore County we don't really find that the absence of a crib is a big risk factor for us. In fact, many of our kids die in situations where there was a crib. It's just not being used. So many child death review teams will need technical support in terms of identifying strategic response. And there is, in fact, an excellent resource funded by the Maternal HRSA and the Maternal Child Health Bureau, the National Center for Child Death Review, and the website for that is up here for you. But the reality for us is that whenever a child death review team sees something which has high levels of exposure, in other words, all infants sleep a lot, and poor outcomes associated with that exposure, that makes it a priority issue for us. And in this case, for many teams around the country, infant sleep safety has become a priority issue. So how then do we think about reducing the risk for infant sleep environment deaths? So despite the apparent drop in SIDS, and there was a lot of press attention to the drop in incidence of SIDS around the country, what's really happened is that there has been some drop in SIDS incidence, but really what there has been is a transition to calling these cases SUDI. So we've had decreases in SIDS, but we've also at the same time had increases in SUDI deaths. And we have dramatically increased our call of SUDI in Maryland. From the 1990s, where there were probably more SIDS than SUDIs, we're now at a situation where we definitely have many more SUDIs than we have SIDS. And the majority of SUDIs are, in fact, really related to unsafe sleep positions and are immediately preventable. The key risks being co-sleeping, or we prefer to call it bed sharing, because in some cultures, co-sleeping is sleeping in the same room. Prone sleeping, in other words, sleeping on their stomach, babies sleeping on couches, water beds, and then, of course, the issue of blankets, comforters, and pillows. Just wanted to show you this slide quickly so that you can see that, SIDS, we drop off occasionally, but SIDS has been running pretty steadily. This is 2003. If you'd looked at this slide prior to the 2000s, you'd see SIDS being much higher. We made our transition in Maryland much earlier to SUDI than many other jurisdictions. But in fact, SUDIs are running about 2-to-1 in terms of SIDS in Maryland. The problem is that these all get lumped back as SIDS when they go to vital statistics. But for our purposes, we need to understand that what we are really paying a lot of attention to in Maryland is the issue of the SUDIs. And that brings us to a critical issue, which is the back to sleep message associated with the SIDS risk reduction campaigns is completely inadequate when we are talking about SUDI prevention. And that is because we are finding many kids back to sleep in unsafe environments. So this kid is back to sleep. As you can see, one of my colleagues sent me this picture because she's heard me talk about sleep deaths so often. This was a child she saw back to sleep in a crib. However, she has a lot of company in the crib, which puts her at great risk for SUDI death. So our focus in terms of thinking about prevention is the issue of changing what we call ecological imbalance. Here we have this EPI Triangle, but the way that I like to think about it is that in fact the agent and the child are interacting with the physical environment really as the fulcrum around which they interact. But the social environment shapes the way the physical environment interacts with a child. So in other words, if I have an infant put in a fundamentally unsafe sleep position in terms of a bed full of pillows, comforters, and pets, as you will see in a moment, the social environment is what's going to determine whether people make that choice or don't make that choice. And so what we want to do is to change the way people look at and respond to physical environment. And the way to do that is through social environmental change. The reason it's important to change the way that we as communities of people think about physical environment is that this will then increase the demand for the design and availability of safe sleep-related products. So here is the product which allows parents to keep a baby next to their bed, lift the baby out for breastfeeding, put the baby back in, but the baby is still separate from the bed. This crib that you see here, this porta crib, is an example of a similar product development, very affordable. Unlike the basic porta cribs, this now has the higher level bassinet component, which means the baby can then be rolled right next to the bed. So this is a response to consumer demand. Consumer demand drives, of course, product development. And that's why we have to work on changing social norms about how we want our babies to sleep. And what we ultimately want to be doing then is changing the way that people think about physical environment so that people make the physical environment protective of the infant, so that we have less vulnerability of our infants. So social environmental change is essential, but unfortunately social norms are against us in this country. And in case you don't believe me, I want to ask you this. When I show you this, oops, she did it again, who is she and what did she do? Come on, the people in the audience can tell me this. Who is she? Britney Spears, and what did Britney do? Right, Britney placed her infant son in a high-risk situation in a motor vehicle. And there was huge and immediate public outcry because of this. And this says to us that there is public awareness of the risks to infants in cars and the need to use an infant safety seat. So what that response showed us was the very high level of awareness of risk in motor vehicles and the need to protect children in the physical environment in a car. This actually provided us with a great prevention opportunity in this country. We got so much interest in child passenger safety. However, what did Jennifer Lopez do? Anybody want to know what Jennifer did? This is a fascinating example because what Jennifer did, in fact, nobody paid attention to, or almost nobody. Scott and I saw this magazine and immediately talked to each other in horror over the phone, but in this magazine, Jennifer shared pictures of their twins' luxurious nursery and described their co-sleeping with their twins because they couldn't bear to be separated from them. So some of us, our blood pressure immediately rose when we read this article, but generally there was no loud or immediate public outcry about this, indicating limited awareness of sleep environment risks. I subsequently found that there was a response. Parents Magazine sent a memo to J-Lo in which they said, "Dear J-Lo, parents, staffers were kind of shocked at the photo of the baby's ornate Versailles-like nursery, which is filled with safety hazards. We want those sweet twins to stay out of harm's way, so we're begging you, please baby-proof." And they go on talking about the pillows and the stuffed toys and so on, but nowhere do they mention the fact that they've talked about bed sharing. That's never mentioned at all. This then, of course, generated a whole lot of response in the blogosphere. Some of them dramatic, such as Jennifer Lopez's 100K nursery will kill her babies. But the thing that's so fascinating about this response is if you follow this response on the web, there are so many negative responses to these comments, like, get over it, J-Lo's fine, she loves her babies, why are you being so critical? And the more that you actually follow the path of these discussions, the more that I, for one, became convinced that people truly do not get the issue that kids are at risk. We have some real challenges to behavior change in terms of sleep environment. The first is that we are certainly, in terms of stages of change, very much in pre-contemplation here. In other words, that people are either unaware of the problem or they've decided that it's not an issue and they're not going to change. So we have the risks of unsafe sleep environments either not widely recognized or in some cases discounted. In other words, it's not going to happen to me. I'll wake up, I won't turn over on my baby, I'll wake up. But any of us who've ever had kids can only begin to describe to the rest of you the profound fatigue that comes with being a parent. And so the tragedy is that tired parents do, in fact, roll over on their babies. The other issue is that those contemplating positive change may be discouraged by peers or by public opinion. And in fact, co-sleeping or bed sharing is a common practice and has many outspoken advocates. There are how-to books talking about how to co-sleep safely. There are magazine articles talking about how to sleep safely. There are numerous blogs, testimonials, and photographs, all telling you how to do it safely, but the reality is that most how to co-sleep safety information is accompanied by photographs that show unsafe sleep practices. And if you would like to explore this, Google or search co-sleeping and use image in the search term, and you will find all sorts of horror pictures. These are just Creative Commons pictures. In other words, they're not copyright protected. But let me show you this. Here we have dad, baby, and large dog sharing a bed with comforters and pillows. Here we have dad, baby, and even larger dog sharing beds with more comforters and more pillows. And here we have baby in his crib with bumpers, pillows, blankets, and a large black cat. Moving right along, here we have baby sleeping with mom and dad, back up against a comforter, face underneath the pillow, in case you hadn't noticed that. Yeah, I heard the gasps in the audience. Those of you remotely missed out the gasps that came from the audience, but here's another one. And finally here, another example of dad and baby, the pillow here, and then of course finally the child and the brother. The reason I included this picture is because many people are so afraid of a child falling out of bed that they will actually prop the child with pillows around them. And in fact, the child would probably be safer falling out of the bed and landing on a carpeted floor than they would be protected from the fall by lots of soft pillows. So we just need to consider that. Now, safe sleep education is inexpensive. It can be done in many settings, as Stephanie mentioned to us. But the real issue is it's inexpensive, but it's not easy. And we need to move beyond this basic brochure distribution, you know, handing out paper, killing trees, and putting paper on tables at health fairs. We need to get a little more strategic than that. So safe sleep education is needed to change social norms about sleep environment-related risks. It needs to be addressed early. In other words, when people are pregnant, not when they already have the baby. It needs to be addressed early, and it needs to be addressed often. It must involve credible key informants, key influencers, and key messengers. So not just the pediatrician or the nurse, although they're critically important, but people like the mother-in-law, the grandparents, and so on. It needs to be institutionalized in settings such as newborn nurseries and pediatrics, and Scott will talk about that. It must also address the barriers to adoption and the opposing messages. It's not enough that we give them this ideal message and then they find the opposing message when they get out. We need to preemptively tell them that people are going to challenge this, and then it must be repeated and reinforced at the community level. And the education is not just for parents. We, for example, in Baltimore County, we've worked with police and EMS, not just to have them talk to parents, but so that they can provide us with essential information, such as telling us about the presence and use of a crib, or telling us about sleep position, because the better the information they give us, the better our ability to prevent is. Daycare providers, babysitters, grandparents, and other people who deal with infants at other settings. For example, a colleague walked in and found at her church infant nursery babies sleeping on their stomachs, and so was able to address that issue. Physicians, nurses, childbirth educators, social services providers. We have our social services providers carrying material, are all valuable influencers. And we have started to work with the child passenger safety community in that parents coming for infant child seat installation who are aware of risk in the car, we find it then easy to connect that risk in the car to the risk in the bed, and then piggyback the infant sleep safety education onto the child passenger safety education, and so on. So changing behavior is challenging. It's very, very challenging, but it is possible. And so that we can hopefully persuade you of the fact that it is possible to make these changes, I'm going to hand over to Scott Krugman now.
Unfortunately, I have to follow Carolyn, which is not very nice, because she's so good. So I'm going to be speaking a little bit about our experience in Baltimore County and then our response, at least in our hospital, about what we've done to try to prevent sleep-related deaths. So in the 5-year period from 2003 to 2007, we really started to see a spike in infant sleep deaths. Before that, a lot of our efforts were focused around child abuse, abusive head trauma, prevention of that, because there was a whole spate of cases in the late 90s in our area about that. But all of a sudden, right around 2001, 2002, things were shifting, and by 2003, it became real clear that sleep-related deaths were the biggest issue. In this time, in the whole county, all of Baltimore County, which surrounds Baltimore City, 69 infants under the age of 1 died. 60% were male, 55% were white, 35% African American, which is a disparity because our population is about 19%, and 6% Hispanic, which is also higher than the county population. The average age was 113 days, with a range between 7 days and 325 days. The majority were right around the couple-month period, right around 3 months. And all these cases fell in with sudden unexplained deaths and had the same death investigation as Carolyn mentioned before. And what was interesting was that the cause of death really didn't have a lot to do with the true underlying reason for the death, with being the sleep environment. So of the SUDI cases, 32 out of 33 were sleep-related. Of the SIDS cases, 12 of the 13 were sleep-related. Of the asphyxia deaths, 2 were sleep-related. 1 wasn't in an unsafe environment, and 1 was just not even sleep-related at all. So it didn't really matter about the cause. Their sleep was the common denominator that led to the child dying. So we found that 46 of the cases, 67%, were purely sleep-related. These are the deaths that we feel were entirely preventable and that we could have a significant impact on. 6 of them were in an unsafe environment, but there are other factors present. 5 were homicides at a very low rate, about 1 per year. 1 car crash death. So a lot of time and energy focused on car seats, and that was a pretty uncommon cause of death. 9 medical conditions, 1 foreign body, and 1 remained unknown. So overall, 75% died in an unsafe sleep environment at the time of their death. So that's a pretty high number. And just to kind of relate to you what that looked like on a year-to-year basis, these are 100% graphs where no matter what the number was, this is all the infants who died that year, 2003 to 2007. And as you can see, between 60 and 80% each year of the infants who died in an unsafe sleep position. So this was clearly an issue for us, and we really need to start to do something about it. Where did they die? The adult bed was the most common culprit, over half. Bassinets, cars or bouncy seats, couches, cribs, unknown, and swing. So not a lot, but the big focus is the co-bedding and having kids, little infants, in big adult beds. Our hospital is located on the east side of the county. We're in a high-risk area. We're not as rough off as Baltimore City, but we do have issues with substance abuse, domestic violence, child abuse, the usual sort of inner-city ills. And our ER docs got a little upset because the kids kept coming in dead, and they didn't like that. They really don't enjoy having dead kids come into the ER. They'd rather treat kids and make them better and send them out. And of the kids who were born at our hospital in this time period, which was 19, 10 of them came back to our ER dead. 9 also went to other hospitals, and then 12 kids who were born at other hospitals came into our ED as well. So of all the kids in this time period who died, about 1/3 of them came through our hospital one way or the other, either born there or dead there. So we have a pretty big impact on the entire county. So if we can make a difference in our area, there might be a difference that can be made in the county. So we felt we needed to start doing something. And this is describing what's going on in our catchment area. Of the kids who are in our area who died, they were almost all dying of sleep-related deaths. In 2003 through 2005, we're up around the 85%, and then finally in 2007 it went down a little bit. But this is a huge issue in our area, so we felt like we needed to do something. And then of the kids who were born in our hospital, we had a banner year in 2004 where every kid that came in dead was from a sleep-related death. So we felt like we had to do something, and we really started to refine the message, and this is not something unique to us. We weren't the first ones to come up with the ABC. We're probably the 100th, or who knows what number we were. But the big message is that kids need to be put to sleep alone, on their back, and in a safe crib. And crib can be bassinet as well. So we came out with this neat little one-page flyer in English and Spanish. We field tested among young parents, older parents, made sure it was clear, made sure people got it, got some feedback about it, and posted it on the Baltimore County website as a PDF so anybody could download it for free. And we started passing this out. We started as a fatality review team with no money, saying, who wants it, who's going to do it, and we did a training for all the daycare providers got it, and we started handing out to all babies born in our hospital around 2005. And that was a start, and it's a good message, and it's our, you'll see the healthy babies are dying. You think that would start to catch on, but it's really not catching on. If in general, we have about 12 kids a year in Baltimore County dying, 12 infants suddenly and unexpectedly dying for no good reason, perfectly healthy. If we actually had 12 die at once in one location every year, people would be kind of freaking out, and there'd be a big uproar, and there'd be big investigations, and the CDC would be here and be going, what's going on in the daycares in Baltimore County where 12 kids each year die? There's nothing like that because they're individuals. So it's an issue that we have to overcome. So back in 2000, we started abusive head trauma prevention program where, similar to what Mark Diaz started up in New York and then subsequently Pennsylvania, we provide all parents of newborns with education about abusive head trauma, how to cope with crying, have them sign a commitment statement, and have them opportunity to watch a video. And our nursery got the hang of that. We've been doing a good job of that. We've been doing it very well. And we have a lot fewer abusive head trauma cases. So in 2005, we said, all right, let's start handing the flyer out. And then in 2006, Carolyn was fortunate to have a public health nursing student who did a lot of work with us and really did an assessment and formative evaluation of our staff. How's the staff doing? Are the nurses talking the right thing? Are we walking the walk? Are we putting the kids in with all sorts of pillows and then saying, put your kid in a safe position, things like that. And the nurses were receptive, the non-professional staff were receptive, the physicians were receptive, somewhat. It was positive, but they needed a little push. But it didn't take long. Once they saw the data, it was a very clear move. And then we had a championship that helped facilitate move this. Clearly, that was me. So we started in 2006 really ramping up the efforts and really changing the culture of the nursery. And it looked like in 2007, holy cow, look at that plummet. Only one case. It's statistically, difference between 2 and 1 isn't very significant, as all of the epidemiologists know, but it did look like we were making a difference, except in 2008 we had 3. So we haven't made a huge effort. So we've now expanded it, just starting in 2008, that we're doing the exact same thing as we're doing with the abusive head trauma. We are having the parents get the information. We're having them sign a commitment statement saying, I am aware of the risk of putting my baby to sleep in an unsafe sleep position, and I'll let everybody know who takes care of my child that to put them in a safe sleep position. And we got a video from Pennsylvania that I have to buy a couple more copies and start showing patients, but it talks about how to put kids to sleep in a safe position. So we're going to have the video too. So we're really replicating our abusive head trauma thing with the sleep safety. And we can knock on wood, there haven't been any deaths really since early 2008, but I'm not counting my finger. We're not quite there yet. And part of it is, as Carolyn mentioned, the hospital is only one piece. There are so many other pieces of the community and so many other pieces to this that we have to work on, that we have to really take the next step. And I think sort of the take-home messages to sort of tie all three of the segments together is that it is clear that healthy babies are dying in their sleep, and this is the most significant preventable cause of death in infants. And we started with infant mortality, and if we, in those 5 years, didn't have those sleep-related deaths, Baltimore County would have gone from an infant mortality rate of above the mean of the state to below the mean of the state. It would have dropped by 1 per 1,000, which is pretty significant. We need to evaluate prevention efforts. It's got to be there's got to be more formative evaluation, and there's challenges by professionals, doctors not talking about it, the community, at home, cultural beliefs, a whole set of natural birth communities that don't believe that this is a problem. There's a lot of change that we need to make. And what we've started to do and what we're trying to get at, we had a kickoff last May with a Sleep Safety Summit to really get everyone involved, think about how can I make a difference in my current role with sleep safety. So not doing something on top of what I'm already doing, but if I'm a DSS worker and I'm going to the house, is there an opportunity where I can say something? If I'm a doctor, can I do something? What if I'm a nurse? What if I'm a parish nurse? Is there an opportunity at church where I can say something and make a difference? And we've got to get to the media. And we've had events in the city, we've had events in the county, and no media show up. It's just not hitting the radar screen at all. And I think unless they get the picture that 12 infants are dying, boom, out of the blue, it's small numbers, but it's a significant impact, and we got to keep pushing that. So we're working on the community. It's a lot of work, and I don't think we're quite there yet, but we'll keep trying in Baltimore County. So we are now to the question and answer session. And
Great. Thank you. I'm going to take this over there, and for people who are watching online, just a reminder that you can email your questions to our email address at MAPHTC. I know I'm not being picked up by the mic, so I'm going to say it over here. You can email your questions into maphtc@jhsph.edu. And in the meantime, we will be able to take questions from people here in our live audience. So if anybody has a question, please feel free to jump in. Yeah.
You mentioned talking about the difference between SIDS and SUDI and how Maryland has started using the term SUDI. How did that transition occur within people defining these things and investigating this? I mean, how did awareness develop about using that term over SIDS?
I'm going to repeat the question so that people out of the auditorium can hear it. The question was, we talked about the difference between SIDS and SUDI and how in Maryland we came to the point where we started defining it and using the different terms. Maryland has always had a history of being very focused on child and infant death. That's been an issue for years. The previous chief medical examiner, Dr. John Smilik, did a lot of work on SIDS and was really interested in that. He also brought into the medical examiner's office many years ago a pathologist, Dr. Ling Lee, who is still there, much to our delight. And Ling, as a forensic pathologist, has focused a lot of her research on infant death. And I think, you know, with the QA protocols that they have, with all the pathologists sitting around the table talking about the cases at sign-out rounds each day, it became very clear to them that there was this consistent pattern of, you know, sleep environment issues and so on. And so I think, you know, when you have 16 or 17 pathologists, you begin to have that awareness just of the huge case numbers. And it's not, you don't have to wait for it to transition from jurisdiction to jurisdiction. And so back in the 90s, the office began to call some of the deaths which had the clear environmental risk factors SUDIs. In the rest of the country, many people call them SUIDs. I think we just thought SUDI is easier to pronounce. But certainly in the 2000s, as the work that Ling has done and others have done has increased, as the involvement with the pathologists on child death review teams has increased, because in fact most of the metropolitan counties in Maryland not only have a medical examiner who attends, but they have their own medical examiners. So, you know, the same person shows up every month to that particular county. And I think as that awareness increased, the tendency to call them SUDIs has increased. It really has to be almost completely negative for us to call anything SIDS in Maryland anymore, which makes Dr. Krugman happy.
Well, and also at the same time, over the past decade, the American Academy of Pediatrics and the pathologists got together and really said, what is the definition of SIDS? The original definition came out in the early 70s, and it was very broad. And the piece about the scene investigation really came out in the past decade. And that really took the change from just calling any dead kid, dead infant a SIDS, which still does happen, unfortunately, in a lot of places around the country, to did we cover all the bases and did we do a full autopsy? There's still counties where there's a coroner who has no experience at all who will walk in and find a dead baby in a crib and call it SIDS, and could have missed all sorts of things. It could have missed the sleep position, could have missed the subdural hematomas, could have missed the metabolic error. I mean, there's a lot of different things that are being missed. So when we look nationally at data, it just stinks, and it's very hard to get a good grasp of it. So part of the reason we do the fatality review locally is to have local data, and at some point we'll have good national data where we can actually track and trend these things.
And I also think there's a lot of people out there just talking about it. I mean, Scott's done a lot of work with AAP. You know, I've talked at forensic conferences. I'm sure Dr. Regenold's done the same thing. You know, I think that many of us are really passionate about this because it is so preventable. And when you think of just so many of the other challenges with infant mortality, it's just huge systems issues that have to change. And this is a guaranteed win if we can get to it.
Yeah, I think part of it's just sort of an evolution of our knowledge. You know, we called SIDS a diagnosis of exclusion. So when everything else has been ruled out, well, then we find all these risk factors: sleeping on the stomach, soft bedding, bed sharing, and then, well, do you call it SIDS if we haven't excluded that? So I think with our knowledge, our definitions are changing, which doesn't do much. It doesn't help much when we're looking sort of nationally at trends because everyone's defining it differently.
How important is the terminology here for public health messaging? Because it seems like the SUDI gets kind of confusing. And the way that we've been doing it in Baltimore City is more just calling everything SIDS, but is there an issue? Do you all think that there should be a distinguishing factor in our public health messaging related to this subject? That's one question. I have a couple.
The issue was how important is this language, because isn't it confusing to have SUDI and SIDS, and in the city basically you're talking about it as SIDS. I think it's really important that we distinguish them because SIDS is a diagnosis of exclusion, and I think people still make a lot of assumptions about SIDS. But frankly, what I think you'll hear us doing is we very seldom in public talk about SIDS and SUDI. You'll hear us talking about sleep environment-related death because that's a shared risk factor. And one of the things, as a public health intervention person, for me, the message always should be about, well, what is the issue, not what's the name. And so if we call it sleep environment or unsafe sleep-related death, in our very messaging, we've already told people what the issue is. We're not using a medical term. And so I think most of us in this area are beginning to transition to using that language.
Yeah, I agree. There's a lot of places that talk about SIDS. A lot of, the pediatric research meetings are coming up in Baltimore in a few weeks, and there's a whole big symposium on SIDS, and everyone talks about SIDS, but they're really missing the bigger picture of this is unsafe sleep positions, period. And that's what we talk about because the overlap is there. I mean, you have so many causes: the asphyxia, the asphyxia natural, you have SUDI, you have SIDS. It doesn't matter. They're unsafe sleep. If we keep saying unsafe sleep, dead babies, it's much better likelihood to make a difference, I think.
Yeah, I think one thing though that is tricky is that people recognize SIDS. If you ask a general audience what are the major causes of death among infants, they're going to say SIDS, and in that sense, it's recognizable. And often we try and work with that to gather support for our messages. So it really is confusing. I mean, I had somebody recently at a DSS office say, well, isn't this crib death? And I mean, so we have, I think, from switching from stomach to back, from calling it SIDS and SUDI and crib death, it has created a lot of confusion. And I think the medical community, has some, if not responsibility, some explaining that to do.
The question related to smoking and sleep-related deaths, and how much we want to start incorporating that into we use the ABCs of sleep as well. But it seems like in many of the households where we're finding these sleep-related death cases, there's smoking that's going on, whether it's the mom or the dad or grandmother or whoever it is. And it seems, I don't know how much of an attributable factor smoking is. I know that it's a contributing factor, but Is that something that you all are considering in Baltimore County as part of the campaign? Is it something we should be thinking about?
It's funny because I was just at the state child fatality review team and got the exact same question. Oh, sorry. The question for all you out there is what's the impact of smoking, and are we considering using smoking messages or stop smoking messages in our prevention materials? And I had just gotten that same question, and we haven't looked at that factor with our data. And part of it is getting that data and making sure that the scene investigation records that, because when we do our reviews, that hasn't been on the top of our head, and I think it needs to be, and we need to look at that to see if that is one of the big impacts, because maybe it's ABC, don't smoke, or something like that. So I think that the verdict's still out there, but clearly it is a risk factor.
Yeah, we've certainly seen that, as you said, in Baltimore City. I think over 90% of the cases of sleep-related deaths in the last 5 to 6 years, there has been smoke in the environment, and that's only that we know about those 90%. The other 10% we just don't know. So that is an overwhelming statistic. And when I tell people that, there's always this collective, dropping of the jaw that smoking has such a great effect.
And we actually had this conversation with our police representative at Child Death Review this month, because we've seen less reporting of cigarette smoking than we used to see. I mean, early on, they would tell us about it. And we asked sort of why we weren't seeing it, and the response was, well, when you see a baby with a pillow over their face, you sort of don't think about smoking. And we actually had a discussion about how important it is and the fact that we would like to know it. And I think it's important that we know it, and we may also want to address it. As a preventionist, let me tell you what my concern is. I mean, I'm a big anti-smoking person. The other reason is smoking is also the leading cause of fatal house fires. So I'd like to see the smoking out of that too. But, people really, I think, have a hard time believing they can give up smoking. And so if we say you can keep your baby safe by giving up smoking, it's a good idea, but it's still a big undertaking. Deciding not to put them in the bed and keep them in the crib, that's a much easier thing to do. And so one of the principles of prevention is always to firstly find the modifiable risk factor and to find the easiest possible modifiable risk factor. So yes, I think we need to keep looking at smoking, but I still want to stay very, very focused on those beds. So the question is, in Baltimore City, you're trying to engage police officers in the safe sleep work, and how have we done it? I think the issue of a champion is so huge. In Baltimore County, the previous person we had on our team, Lieutenant Craig Bowers, had been involved in child death review at the state level since 1993. So he was the first police officer to truly engage in child death review, and probably in the country, one of the first police officers. And he'd done a lot of advocacy work for us around the state in terms of encouraging police departments to get involved in child death review. So to be quite honest, we had a wonderful champion. And he was running the homicide unit, and although police don't show up and say, hey, we're homicide, the reason they had homicide respond was because they're trained observers. And so they didn't respond as homicide, they responded as investigators. And so there was this real awareness in all the police that they had to be getting the data, they had to be, collecting it. And one of the things that Craig said to us, which I think really made an impression on Scott and on me, was how stressful it is for a police officer to respond to the scene of a death. Many of them are young, many of them have their own children, and it's just incredibly emotionally stressful to be in a home with a dead baby. And he actually pointed out to us that maybe giving the police officer something to do in terms of things to look for, things to be recording, is actually very helpful. It helps them feel a little less uncomfortable. But equally, they want to stop it. They have become police officers to serve and protect, and they want to protect. And so I think that's where we began to get the connection. Craig has subsequently retired, and we have a new lead in homicide. But You know, there was an automatic assumption that the new person would be part of child death review. There's an automatic assumption that that's part of the job description, is to be part of this team. So there are always transitions, but I think we've been very lucky. The other thing that I must say that practically is helpful for us in the county is that we have one police jurisdiction. We don't have multiple, you know, police, sheriffs, and so on. So it's easier for us to get traction once the police department buys into it, then we're very privileged because it's easier to get traction. But I think, you know, I do think that public safety people, whether they be police, fire, EMS, they're tuned to saving people, to helping people. And I think the issue for us is how we frame it for them. If we frame it as another sort of law enforcement responsibility, we might not get traction. But if we frame it as a way to actually serve and protect, I think we get more traction.
Okay, we have a couple of questions from our online audience, and this one comes from Texas. For programs that are beginning new SIDS/SUDI prevention campaigns, what types of data collection tools do you recommend to determine whether the outreach campaign has been impactful or whether deaths are declining due to other factors?
So I think the simple answer to that is have a good child fatality review team system, because there is no statewide tracking, national-wide tracking. There's no data that you're going to be able to ask your health department for that's going to get it to you, or your medical examiner's office. You really have to have, if you're in a county that has kids born in the county and die in the county, you're in good shape, because whatever you have is it. We have some challenges across city, county lines, across county lines, where you do have to make sure you're collecting the data on any child who either died in your county and who died in another county but lived in your county. So you want to be able to track all of that. And it's pretty easy to get from the health department or vital statistics how many kids in the county are born. And then you just do the math, and it's really not that hard, because if you start tracking every year, what we've been doing is how many deaths were there, and we focused on under 1. Really, the sleep death risk is under 6 months, but if we, you know, our data would look even worse. Like, it'd be about 90% of deaths under 6 months are due to sleep-related positions. But if you pick your variables and monitor it, and make sure that your medical examiner or coroner's office is online with doing the investigation consistently, because if you have an inconsistent investigation where 1 month everything's a SIDS and the next month everything's a SUDI and the next month, I mean, and we can run into that once in a while too, because we have some variation from forensic pathologist to forensic pathologist on how they'll call things, but in general the investigative process is the same. So you want to make sure that's being done well as well, and the child fatality review team is the best forum for that, because it is, most states have laws in place for sharing of information, for collaboration, for being able to communicate, because it's often a challenge with certain entities like schools or other like mental health providers that don't want to release information, and you have the access to that information. If you have those people at the table, they can get the information for you. So we've been very fortunate to have the head of Child Protective Services be able to bring the case reports, the head of homicide bring the police reports, the head of the EMS bring the EMS reports, I'll bring the medical, we can get the information. So having the information is key, and there's some great tools on the national website for child death review with what things to look for, and the CDC's coming out with some standardized guidelines that everyone should start to be doing.
Yeah, the CDC has a standardized death review, death scene investigation form. It's not mandatory, it's just voluntary right now, but it is on the website on CDC's.
The other thing that I'm thinking about as an implementer is the need to actually document whether we're doing the counseling and what the interventions are, because I think that, you know, trying to link our activities to our outcomes is tricky if we don't have evidence that we've actually done the implementation, which is why it's so exciting that Franklin Square is actually going to the documented response. And we're trying to work with that now in the county. That's something we're starting to work on, because one of the public health nurses drew my attention to the fact that, you know, anecdotally they're beginning to see evidence of overlapping interventions. So for example, I think there was a slide where we said we design the material, Franklin Square uses it, social services carries it, EMS has it, the nurses had it. And one of the nurses came to me the other day and said, I took this material out to talk to the parents, and we use the same material. We don't want different slight messages. It's exactly the same material. And she said, I took it out, and the father said, oh, I've seen this. This is the third time I've seen this. And so then the issue is not to say, oh, I'm sorry, and put it away again, but to sort of reinforce that. So trying to actually sort of have people document their counseling and to document situations such as this, where people say, I've heard this, you've told me this, or, my church told me it, or whatever. I've had people come in and say, we were at the homeless shelter, or we were at this place and we saw your sleep safety materials, places that we've never distributed those materials. So clearly they've been downloaded from the PDF files. So I think there are ways to begin to do that, but that's very contextual in terms of what's right for the environment.
I think that's another great point. With our abusive head trauma program, most data in the literature has about a 70% response rate, and we've been able to get up to about 95% over the years with signed commitment statements from moms and 70% of the dads. And we're looking to see the same with sleep safety, and you really want to track that, because if only a third or a half or even 2/3 are getting the message, then you can't be sure that you're actually getting it out there. So you want to be able to make sure you're tracking your implementation as well as the outcome data.
I just want to make a quick final comment. I think there are other things that we're not. We're actually going to put some people into Franklin Square to observe the counseling again, because I think there are things that you don't know are happening. For example, we had this lovely situation at Franklin Square where a television station went to interview Scott in the newborn nursery about the sleep safety, and happened just to sort of surreptitiously go and talk to a mom. Completely uncoached, unprepped, and they basically said to the mother, sort of, what do you like about this hospital? And she went into this whole big thing about, they really care about my safety, and this is my third child, and nobody's ever told me how dangerous cribs are. And she gave them this whole lecture on sleep safety, and which was showed on television. And it was really wonderful, because this was prior to her discharge, so it was quite evident that the staff in the newborn nursery is modeling the correct behavior. In other words, when they take the baby from the mom, they're doing the talking. And that may actually be what's doing it, as opposed to the counseling. And that we've got to get at how to measure that. And I think the way to do that as an evaluator is to go in and observe it and have a look at how it's really playing out in the real world, and then place measurement steps at that point. But what's changed at Franklin Square is the social norm in the clinical staff. And that may actually be what's driving the change and not the messages.
Go ahead.
I want to congratulate you on the work you have been doing to date. It seems very exciting and coordinated, and that's fantastic. I was wondering if you could talk a bit to the efforts to change the social norms within the household, where these actual, the baby is being put to sleep, etc. Some of the research we've looked at has said, yes, I've signed the commitment letter in the hospital, but then I went home and my mother-in-law said, do such and such. Could you talk a little bit about what you're doing to try to get into the home, and looking at decision makers, etc.? Thanks.
We'll take any ideas. Let me repeat the question. The question was about how to get into the homes and how to change the social norms in environments, because no matter what education we give, grandma's going to say, well, I put you to sleep on your belly and you were fine and there's no problem, and there's a lot of pressure inside the house. And I don't think we have the solution yet. I mean, we've tried media campaigns, we've tried flyers, we've tried press conferences. Clearly with things like the J-Lo versus Britney Spears response, it's not there. We're not at that point in this culture. I think we're kind of like where we were with smoking in the 60s. Some people are thinking it's bad, but the doctors are still smoking. So we've got a long way to go, and it's, I'm open. That's not my area of expertise, so anyone who has research funding and like social norm change, come talk to us. We're ready to roll with you.
Well, I can tell you in Baltimore City, we have home visiting programs that are already set up and targeted for high-risk populations. And what we've done is educate all the home visiting advocates on safe sleep, and also to make sure that they're looking in the home and seeing if the baby's sleeping in a safe environment. We have cribs distributed to families when there isn't a crib, and along with the crib distribution is safe sleep education.
I'm trying some other strategies, given that prevention is so dramatically underfunded, and I just couldn't be in the homes. It's like 0.5 FTE of me. I've really been thinking about how to get into the homes, and we use our public health nurses, of course, and the social services people, but one of the groups that I've worked with a lot are the EMTs and paramedics, because they are actually the only group that is welcomed into the homes 24/7, 365. And we've done trainings with EMTs and paramedics. We actually have now, we've developed a 2-hour module that is part of the paramedic training program, which is called risk reduction. It's not called injury prevention, it's called risk reduction, and we actually tie it to the concept of size up, which is very much something that fire and EMS understand in terms of sizing up risk to them and risk to patient. And so we've been training them in observing environmental risk. And the example we use in the training, the working example that we use in the training is in fact of infant sleep death. So we've had the opportunity now to place that into the training in the Fire Academy in Baltimore County. We are also about to put sleep safety materials on the medic units, all the medic units in the county. And we have dolls for the EMTs and paramedics to carry. Clearly they're not going to do this if it's in a really emergency situation where they have to grab and run. But they're a small percentage of EMS cases. In many cases, they either have time before transport or they don't transport at all. And also, in many cases, the EMTs have relationships with families. They know them well. They're responding, a lot. So I think that there are opportunities. There is also, just for those of you who are in other jurisdictions, EMS, especially EMSC, Emergency Medical Services for Children, has a mandate that fire and EMS be doing prevention. And typically they sort of go out and do health fairs, bike helmets, rodeos. But what we've been doing is saying, can't you integrate the prevention into the daily work you do as an EMT? And we've had great support from our EMS community. Quickly, one other comment. Remember I said that the messaging has to include the response to the barrier. So when we do counseling with mothers about sleep safety, we actually walk them through, now when you get home, your mother-in-law may say this, or your best friend may say that. And so we actually sort of do mental rehearsal with them in terms of, this is going to happen, and so what's the response to that? But this is why we have to be driving social environment, not just in homes, but outside of homes, because if a young mother is talking to her friends, or is going to the gym or to her church, and is hearing the same thing from other young mothers, she may be more persuaded to stand up for her baby's safety than she would if she's the only voice for safety and everybody else is opposed to her.
And that's part of the strategy in Baltimore to improve birth outcomes, is to really get this on a community level, in all the places in a community where maybe not just the mother, or maybe not the mother or the father, but the grandmother might be going to the church, or the aunt might be going to the community center, and really trying to get it out there.
Okay, just a couple more. We're running out of time, but from one of our partners in Delaware, a question about whether, in your opinion, is there any safe way for a parent to share a bed with an infant?
No. I think the key is the bassinet or the sleeper that makes it a co-sleeping environment, where the infant is in their own little protected area, not with the parent. I think there's been some more recent data about kids who aren't used to sleeping on their belly, put on their belly, or aren't used to co-sleeping at higher risk than those who aren't. So the challenge is, what are you doing at 3 in the morning when you're exhausted? And how do you get that kid back into the safe environment? And it's not easy. I think, Carolyn and I reviewed an article in Mothering magazine that had keys to safe co-sleeping, and one was, have one parent be alert at all times. Well, how do you do that at 3 in the morning? Oh, you're the one watching the kid now? Are you kidding me? Everyone's sleeping. So I don't think, you know, everyone says, oh, it's just the families where there's smoking or just the families where there's drinking. It's not. I mean, we have kids in all sorts of environments, on the chest of the dad while he's sleeping on the couch, who the kid slips off and gets stuck in between. I mean, we had a 1-week-old with that. That was the 7-day-old there. It's tragic. It is, you know, they just get out of the nursery and the kid's dead. I mean, it is the worst thing there is. So I would say no, and you know, having the same room is fine. Putting the bassinet right there, up to the bed. It's you know, roll over, feed, put them back, roll back to sleep. That's the way to do it.
I was going to say, this question comes up all the time. I work with First Candle, which is a national nonprofit devoted to infant health and safety. This question comes up all the time. People say, well, this group of moms I'm talking to, they're bed sharing anyway, so how can they do it safely? And really, as Scott said, there is no safe way to bed share. The actual top proponent of bed sharing in the country goes by doctor, but he's an anthropologist. And the list of how to co-sleep safely, no one who ever has had a baby can possibly conform to all those.
And that's why these products, and I have no shares in this company, but that's why these products are so exciting, because some of the cribs, which are designed to have a side come down and go next to the bed, are quite expensive, and so they're often only available to the privileged. And some of the sort of side sleepers. Whereas this is actually one of the least expensive porta cribs. It's something that many families choose to have for reasons other than safe sleeping. But it's new design now with that inner bassinet. I don't know, I think the camera can probably get at it. With this shadow bassinet means that can be rolled right up next to the bed. The baby can sleep in it right next to the bed, but it's also useful for other things. It's not just useful at bedtime. And so the parents sort of buying one, getting one free. And this is really a response to market demand. And I think the more parents who want affordable options for having the baby be right next to them, the more likely we are to see those products be developed.
Okay. We have another question online, which is, what are the effects, if known, of children sleeping on their stomachs if they surpass 6 months of age 1 or age 1? Are there some health issues that may develop in the future from this way of sleeping?
No, I mean, pretty much once a kid can roll over, well, they're out of trouble, and lots of kids can sleep on their bellies. And one of the things that Carolyn and I put in our little letter to Mothering Magazine was, feel free to co-bed after 1. The risk is much less, and if you want that for your family, go for it. But you at least have a 1-year-old to co-bed with. Whereas if you co-bed under, 2 or 3 months, you're putting your kid at significant risk. So I'm not worried about 6-month-olds who are very good rollers who happen to roll over on their stomach in the middle of the night. That's not a concern. We're talking about the little infants who can't roll yet. So once they're older, do it. And if they can handle a pillow older, you can give them a pillow too. So I wouldn't worry about that.
And related to the sleeping, one of the criticisms we often hear is that babies need to be on their stomachs to develop. And that's where you'll hear the sleep safety advocates talking about back to sleep, front to play. Because babies do need tummy time to do the kind of developing and the pushing up. So the issue then is when they're not in their beds, to make sure they have time on the floor, learning to push up, learning to manage themselves. But they don't need to be on their stomachs in their beds.
Okay, I think we have time for one more question, if anybody has one. No? Okay, I want to thank you all so very much, and I really want to thank our presenters who did just a fantastic job. And I'd like to urge all of you to join us next month, and we are going to be a little off schedule next month. We'll be May 13th, not the third Wednesday of the month, and we are going to have 2 speakers talking about men's health. So we hope that you'll be able to join us for that, and again, a big round of applause for our speakers today.